Who cares where the doctors are? The expectation of mobility and its effect on health outcomes.
Our paper in the academic journal Sociology of Health and Illness explores how medical students and doctors are expected to move around the UK as part of their training. We often think about doctors as an elite group who have the power to make choices about where they live and work. Our paper examines how the organisations and structures that form medical training constrain these choices for some doctors and how this has a long-lasting impact on the provision of healthcare and patient outcomes, particularly for more socioeconomically deprived communities. This leads to an accumulation of disadvantage and highlights the interdependence of training provision, geographical location, and the uneven distribution of doctors across the UK.
The idea that there is a need to ensure sufficient doctor supply in all areas positions the workforce as a malleable commodity to be moved around the country as required. This prioritises the needs of the service over the needs of doctors and unintentionally perpetuates existing problems in ensuring this doctor supply is appropriately distributed geographically. In medical training, each placement is time-bound and accompanied by movement between hospital sites, often in different towns. This affects the preferences that new graduates express and is reflected in what are known as competition rates for each foundation school. Bluntly, some locations are more popular than others.
To show you what we mean, meet Bob and Alice. Alice and Bob both graduated from different medical schools in the same year. Bob and Alice started out at medical school with a passion for cardiology. Bob went to a medical school where placements were offered at one of the leading cardiology departments in the UK. Success attracts success. Bob wins a prize for one of his student projects and has an article published in an academic journal. He does well in his final exams and is allocated to his first choice postgraduate training programme in a prestigious university hospital. He is able to be trained by the best of the best and goes on to specialise in cardiac surgery.
Alice went to a medical school where cardiology placements were difficult to access and delivered a long way from her university. She didn't have a car as a student and had to work part-time alongside her studies to afford her rent. This meant that she didn't have time to write up her student project and struggled to find time to revise for exams. She passed her finals but ended up placed on the reserve list for postgraduate training. In the end, she's allocated to a training programme in a local district general hospital. This is good for her because the cost of living is lower, but bad because she does not have a cardiology rotation within her training. In the end, Alice decides to specialise in anaesthetics, the biggest of the hospital specialties, giving her more scope to find a consultant post in her chosen location.
Medical education and training is a long and complex process interwoven with life events as well as the ongoing complexities of gaining skills and securing professional identity as a doctor. Alice and Bob both meet their partners and have children during their training, leading them both to make pragmatic decisions about where to live and work, as they do not want to repeatedly disrupt their lives. Doctors are trained in order to meet the needs of the health service, but trying to ensure that there are enough doctors in the places which need them is a challenge, based on the perceived desirability of the place.
We know that remote and rural locations frequently struggle to recruit enough doctors to deliver services, and this affects the care available for patients. Thinking about the movement of doctors across different places and over the lifespan of training shows that to improve services, a simple call for more doctors is not enough. Our paper presents a more humanised account of what it means to be a doctor who moves and a reflection on what that means for the quality of care and the regional distribution of health inequalities.